Good afternoon, everybody. Are we ready? One more session in this afternoon of this incredible meeting. And that's going to be a deep dive, really, in TAV procedures. I am Pedro Lemos. I have my co-moderator here, Breno. We're going to have Adam Greenbaum here. Giuseppe Tarantini, who's going to be the first speaker, João Cavalcante, Jorge Chavaria, Sushil Kodali, if you could join us here at the podium. Giuseppe, no need to introduce him. TAV lecture, the first cut is the deepest.
I'm sorry, I don't want to bug you, but I don't want to bug you, but the problem is that I have a flight, so I need to take it. Probably there are some repetition, a few slides that are in overlap with the previous presentation, but actually I will skip. Hi, Adams. So THV and THV, the first cut is the deepest. Actually, I think that this title was selected because this editor that I wrote a couple of years ago, and actually I borrowed from Father and Son of Cat Stevens, actually. This was the reason of this title. But this is my agenda, why it's so important. Planning, procedural optimization, and future perspective. As I told you, there are some overlap with the previous presentation, but I'll try to skip, this repetition. Why it's so important? It is the US valve-in-valve market. Forecast 6% is the prediction of the THV and THV. So it's, a significant number of patients that we foresee to receive this kind of treatment. And why is that? Why is that? Because if the first intervention is TAVR, you have two options. TAVR explantation or THV and THV. When you look at the data, that are not randomized, even not propensity match, but actually when you look at the mortality of TAVR explantation, because this is not a standardized procedure, the surgeon, they're trying to find out a consensus how to deal with this kind of patients. But, with the explantation, you might have damage of membranous septum, aortic root. You can have problem with anterior mitral leaflets. So actually, the mortality rate is up to 30% at 1 year. When you go with the data of THV and THV, seems to be a little bit lower, even though we cannot make a comparison. It seems to be promising. So this is, I'm sorry, but the figure is not appropriate, but I can summarize. When you put together all the studies and you look at the mortality at 30 days, 1 year, or after TAVR explantation compared to THV and THV, everything is numerically in favor of THV and THV because the patients are older than 80 years old in the vast majority of cases. So what I think is that based on that, the TAVR will be likely the most frequent second intervention lifetime strategy in the patients. So the other concept is that not all the self-expandable valves are the same. So the first cut is the deepest again. The first THV choice matter. Let's give a look at the coronary access. Here this is a consensus document of the APCI, February 2023, just to demonstrate that this is not FX plus, this Evolut R. There is a more close cell compared to the Portico, to the Navitor, and the accurate NEO is 2 centimeters, the window at the level of the accurate, so for sure the difference is there. And actually we presented this year a TCT, a lead breaking, is CAVT registry. This is the only one multi-center perspective registry on coronary access after TAVR. This is not a simulation. This is not a forecast. This is a real cannulation of coronary artery. This is the design, 18 European center, 1:1 to 1:1 is a competitive enrollment, 158 TAVI for each type of valve, and actually this is the main results, Spain, Portugal, Italy. When you go for selective coronary cannulation with pre-specified criteria and adjudication committees, 90% for short frame valve is 60+% for the tall frame valve, but the previous edition core valve is 45%. Probably with the FX Plus it's going to be the different, and this is already ongoing, the CAVT 2 for the new division and the FX Plus, but this is the result for selective cannulation. So you have seen already that, but probably Sanjil and Adams haven't seen that yet. So it's important for me also their ideas. We have two types of valve, same durability, but actually we need to consider the risk of coronary impairment or TAVR explantation. So THV repeatability is important. Planning, you know everything about planning, but actually I just want to share 4 new concepts that you need to be familiar. One is the wrist plane and neoskid. The second one is the leaflet overhanging, THV expansion and orientation. What is the wrist plane? The wrist plane is the plane below which might be challenging or impossible to cannulate the coronary artery. What is the neoskid? The neoskid is pretty much similar, but the concept is that is the height of the covered stent that you create in front of the coronary artery. When you put the second valve deep, you have an overhanging of the leaflets and you have at least a perfusion. You will understand why I say at least a perfusion. Doesn't mean a selective coronary cannulation. Another concept is the extra space outside of the frame that you can call VTA, VTC, but we need to be very simple. The concept is the room that we have outside of the frame that permit us to cannulate the coronary artery. So you need to measure this. And actually we have some criteria, what is narrow, what is wide, 3 to 4 millimeter. It depends on many other factors. So what about the leaflets overhanging? I think it's important to know that when you go short and tall, you might have different position for different overhanging. This is not true when you go with a tall and tall, because different position doesn't change anything in terms of overhanging, because the overhanging is 0. Because with the tall and tall, actually, you create a cover stent outside of the first frame. And what about the commissural alignment? Is another important thing. So we need to align pretty much like the surgeon does. And, this is important. But what is, the main take for all of you? The orientation is important. But actually, when you have a very wide ascending aorta, you can cannulate the coronary from outside also. So for me, the most important, decision to go for surgery is when I have a small annuli, when you have a very snug, narrow ascending aorta, when the risk of sudden sequestration for the first or second intervention is there. So the ascending aorta matter a lot and sometimes is overlooked as a factor to consider. THV in practice, what is important, you have seen already, you have to consider a few things for taking these three very simple decisions. Which valve, which sizing and positioning. When you start with a short frame, short means that you can do whatever you want. Tall means that you can do short and tall with some exception. This is a new concept. This is pretty much like for me, I don't know if Sanjil and Adams are with me, is a new concept, pretty much the restenosis in the stent. This is something that is totally iatrogenic. Because we create a structure, this is just a scheme. When we have a native leaflets and we have a stenosis, we put a tall frame valve and we have 2 struts, 2 levels in front of the coronary. Then you go with the short and tall and you may stay below the wrist plane, but actually you have 2 walls to overtake to cannulate the coronary artery. This is one example. But when you go tall in tall, actually, you have 4 layers in front of the coronary. And this structure that stays outside is something that is not natural. It's iatrogenic. It is what we call now sinuses, and it's important to know that we might have some problem because we just consider so far the sinus sequestration. We do the basilica, we have seen so many cases, so many insights from Adams, but this is just the tip of the iceberg of the neosinuses, because this is the acute phase. Then we have a chronic phase. Nobody knows anything about that. We can have ongoing calcification, fibrosis, microvascular proliferation, and what is the clinical perspective of that? Is the valve durability, leaflet thrombosis. You have seen that sometimes, now we're used to see STEMI patients with the TAVI there, we think that it's a plaque there, but actually you do that CT scan and you have a halt process there. Because we need to check all these aspects. We don't know anything, but actually this matters a lot. So what about CT scan? You know everything. By me, you know Joao. And you need to know the height of the coronary, but actually you need to know also the size and the extra space outside of the frame. But you need to consider also that there are some recommendations. When you decide as a first valve to go with a core valve, for instance, we know by the company itself that the general recommendation is when you have a 26 core valve to go with a 23. You need to be careful in that, but you need to consider also that. Because in my experience, I don't know the experience of the other operator, running this registry of THV and THV, we have cases with a 29 core valve that the operator decided to go with a 23, but the valve was totally constrained. The annulus was bigger. And actually, when they went with a 23, the valve slipped down from the waist of the commissure up to the ventricle, and they need to go with a 26 then. So it's really a little bit complex, the process, to decide the size and the position of the second valve. Mechanism of failure is pivotal. As I told you, this is not a class effect. There are valves, you will see a delayed breaking this year at TCT, the 150 register of THV and THV. For some valves, we have 98% of insufficiency. For other valves, we have 80% of stenosis. So there is no class effect, and this matters a lot, the subsequent intervention, because when you have an insufficiency, it's not needed to go very high with the first valve, so there is no risk to avoid the risk to create a neoskirt. And actually, when you have a regurgitation, and actually you can go a little bit deeper to leave an overhanging of the leaflets, and we don't know the fate of this. But actually, for sure, we do not compromise the coronary flow. The last thing is procedural optimization. You have seen also in part this, there is very, very few papers, and Sheil, I don't know if you agree with me about that, few reports on what the importance of valve optimization, just less 5%. A balloon is the way that we can go. You have already seen this. Sometimes 1 millimeter matter in terms of dropping down the gradients, and sometimes we don't need to look just at the gradients, but also at the shape of the valve, because actually when you go with the two views, you see that the valve is constrained, you need to post-dilate it. So this is something that probably is not a novelty, but is important to know for all of you. We need to decode high post-TAVR gradients, because you might face a situation like that. You go with this inaccurate 15 millimeter that is absolutely abnormal. This means that this valve is not optimized with this type of valve. 15 is a lot, because this is not an intraannular valve. But the gradient was considered acceptable at that time, but the patient 2 days later went in the ward, and actually he received the echo, and the echo was 50, the gradients. So what's wrong? So you may say that there is a degeneration, there is an invagination, that is whatever you want, but I'll give you some advice. When you look at the DVI is normal. That means that something is probably not related to halt or things like that, but to the hemodynamics of the situation, because this patient has an hemoglobin of 9, so is an apokinetic, output, so we can, overstate the gradient. But actually, we didn't trust about that because we didn't know anything about that. And actually, we get the patient back, the CT scan was negative in the lab, and the gradient was 10. Why is that? Because we applied the echo evaluation using the continuity equation, but it is inappropriate in many cases because the valvula is not circular. We apply to the surgical valves that are circular, and there is another concept, and now we're testing a bench test, that when the flow fragmentation through the struts create acceleration turbulences, and you take the velocity by echo and not the gradient. So sometimes you have these kind of discrepancies that you need to take into account. So in conclusion, going to the conclusion, coronary perfusion is not coronary cannulation. So I don't like when during the live case, we do the angio, say the coronary are there. For me, it's not enough. This is the reason why we designed the CAVET trial and we went for selective coronary cannulation. I'll demonstrate why. This is two different cases. You cannot cannulate, you see the coronary, but you cannot cannulate the coronary artery unless you stay there for 15 minutes, you use a lot of acrobatics, different techniques, etc., because here the valve was misaligned. But this is not the only situation, because when you don't have an open cell design, you might have the cracks of the cell that stay in front of the left main, and even though the valve is aligned in terms of the commissure, you never get a coaxiality and to be aligned with the coronary artery with the catheter. So you need to know all these aspects. Seeing the coronary artery do not translate immediately through the fact that you don't have to struggle to do a PCI. So in conclusion, Future Perspective, this is the only registry that I know is active. 130 now is 130, so the goal is 150. So I hope that we are able to present at TCT. There is a case review adjudication board, CT core lab, echo core lab. We need to see at all the different things. There is also, let's say, a couple of columns in the database. One is to decide to go with a THV according to the center, and the other column is according to the second opinion of the experts to evaluate the impact of this factor. And in this registry, we want to look at the invasive invasive transvalvular gradient in all cases, just to avoid to see the echo and to have great discrepancies and to try to understand what is the reason of these discrepancies and to go for selective cannulation. Because this is another important point that can make the difference among the different permutation and combination of the valve. So in conclusion, number of THV in THV will rise significantly. A key concern is the coronary access, gradient, pacemaker, and more data are needed for THV and THV durability. The second point, standardization of sizing and positioning is not achieved for me, so we need to take into consideration many things, but we need data. We need data. So the forecast is important, but it's not enough. Valve selection strategy matters. Short frame preserve all future options in case of structural valve degeneration. Tall frame THV requires a short frame for the second procedure. Reduced valve should be factored into the initial THV selection because the first THV choice, the first cut, is going to be the deepest and impact the feasibility of TAV in TAV or TAV implantation as well. So thank you for your attention.
Great presentation, Giuseppe. It's a hot topic we're facing since the progression of TAVR to younger patients and low-risk patients. Certainly, we face this issue in the future. When you put into consideration the priorities for the procedure in the selection of the first device, we have to have the excellent result. We have to have good hemodynamics and also the possibility of future retreatment. Which of these criteria do you put in priority when you treat a younger patient?
No, actually, it depends on two things. The age is important because if I treat an 80-year-old patient, I think, you need to think to optimize what you do, to have a low gradient, to do not compromise the coronary because the valve, I think, outlive to the patients in the vast majority of the case. But the point is that in US, for instance, it's not like that in Europe, so Sanjil can answer to that. They're going to treat 65-year-old patient. So you cannot overlook the fact that you need to think of the whole sequence of this patient. For the surgeons, for many years, just thought to put the valve there. This is the reason why they put also, for me, the sutureless, the stentless, all this type of valve, because they do not think of the sequence. Because when you go with a sutureless valve, you have the same defect of the TAVI valve. Because the frame is very high, you agree with me, Adams? So it's pretty much the same to go with TAVI as a first intervention. With the sutureless, you have the problems of the TAVI and the problems of the surgery. Because you have the leakage of the TAVI and the risk of coronary, the coronary compromise that you have with the TAVI, and you don't have the optimal result of zero leakage that you have with the surgery. So what is the sense of that? I don't know. They just think to the first intervention. You know why? Because they refuse the patient for the second intervention. So this is, but we cannot refuse the patient because the second intervention, as I showed you before, we published the paper, Adams, with 3 interventions in aorta. And the second intervention is more than 80% of the cases is transcatheter. So we need to think about that during the ATIVE. So my priority is if the patient is 70 years old, in Europe we treat 65, 70 when there is a very high surgical risk. Otherwise the patient is going to be operated, to be honest. But if I have to think of the patient with a life expectancy, low risk, 70 years old, that in Italy is 15 years, 16 years of, further extra life, let's say, you cannot disregard the fact that you need to think of the first valve. And if the ascending aorta is narrow, no doubts that it's mandatory to stay below the coronary. Below the coronary. The ascending aorta matters a lot for me. I know, Adams, what do you think about it?
Do you like to do any comment, Adam?
I agree with, if you were to take a short valve and place it below the coronaries, you've taken a lot of worry out of the picture. Now, we combat that with low deployments and chance of block, but I mean, assuming that the coronaries are up high enough and you can place the valve with the coronaries below, it is ideal for second valve choice.
I mean, if I can just make a quick comment. In Minneapolis, we're starting to see more and more of this low risk, low young 70s. And it behooves us to always think, if this patient has been now evaluated for TAVR, can I redo TAVR in that patient? And which are the ones, given that anatomy, that redo TAVR is going to be a bit of a headache, given the anatomy, sinus, ST junction, and everything, that a surgical option will still be more viable for the retreatment. So we got to think on the CT scan in that evaluation, can I redo TAVR? I'm not sure if that is something that has been done wide across or thought in that way, Giuseppe.
So actually, there is another thing that we do not discuss too much, that is the ascending aorta. We overlook this problem, and I'll tell you why. Because now we are getting in Europe cases of aortic perforation in horizontal aorta with a tall frame valve. We need to be careful about that, because the angle is there that all the pressure is over the outer curve of the ascending aorta. And actually, when you have a very narrow aorta and very horizontal, and you push a lot, you can have erosion at the level of the aorta. And even though you have an endocarditis, it's a problem also for TAVR explantation, because the surgeon needs to replace the ascending aorta to go for Bentel. And actually, when you go with a short frame, you don't need to do that. So this is another aspect to consider. So the point is that we need to be very thorough when we treat younger and lower surgical risk patients. Because the risk is to have a kind of, let's say, revenge of the surgical science to say, okay, I told you that you need to be careful and wise, and not to push too much the envelope to put the TAVI to all patients. I'm against that.
And Giuseppe, do you see an increase in valve explantation as time goes by in Italy? And if yes, do you see a decrease in mortality because the surgeons get more experience with that?
Allora, TAVI explantation in our case was mainly due to endocarditis. Because in case of structural valve degeneration, because of basilica, because of chimney, because of many things, the surgeons are really reluctant to operate to explant the valve. Because actually also the technique is not standardized. For instance, in my institution there are surgeons that go for, let's say, a transaortic, they cut the leaflets and put a sapien into. They don't want to explant the valve. Because actually, you know, there is no one way to do this. Nobody knows how to do. Gilbert Angli told me that he's trying to find out the consensus, but probably he's lost, you know, because I don't have any further information about that. No, but I don't see any increase. They don't want to do this.
But I do think that that TAVR, I mean, explants are, you know, the surgeons are doing. It's about volume, because there are skills and tricks to it, and I think that's part of the challenge. Is some of these surgeons are, you know, how to explant a core valve is different than a sapien, and I think that's going to play a role. But I think the key points are what were raised. You know, at every patient we assess, are we going to be able to do valve and valve? If you're a 70-year-old, you're putting a 29 sapien with large sinuses, it's a different conversation than if you're putting a 23 sapien. In that 70-year-old, if I'm putting a 23 sapien, and you're not going to get a great result with valve and valve. And you know, if they have longevity in their family, those are the patients we're sending to surgery. So I think that has to be part of the initial conversation for the patient.
Another topic that we could address, João just showed in his presentation this morning that incomplete stent expansion would probably be related to HALT and RLM. And we just had the session about accurate neo, and we stressed that in addition to hemodynamic and PVL, we also have to pay attention in the valve expansion. Should we extrapolate this strategy to other valves? We implant, for example, a navitor. If you had a good hemodynamic and no PVL, should we stress and post-dilate only because of the anatomy? Is it an epiphenomenon, or we should try to correct this? What is your thought about this?
I think when you do, you know, RO and LAO, 3-cusp and cusp overlap, you see that the valve is constrained, you can measure it. There are measures that you can take. I think it's worth to optimize the valve for me, because there is the HALT phenomenon and many other. I'll tell you something else. The acceleration that you see by echo, even though you don't have a very high gradient, when you look at, you know, the Doppler, the color of the Doppler, you have acceleration. And actually, in this case, you have much more discrepancies between echo and invasive gradient. So I prefer to optimize when it's safe to do that. You don't have to push too much, but I prefer to optimize, pretty much like the stent. So the stent thrombosis is a very infrequent complication, it's 1%. But 1% matters a lot for the patients, that's 1%. So actually, for me, we need to optimize the valve.
Giuseppe, you touched on something that is really important and we're not discussing so much.
The flight.
Yeah,
know?
last one. Which is actually sinus of Valsalva thrombus. So we're talking about, you know, HALT. There is a continuum of HALT, and there is also sinus of Valsalva thrombus, which could be a precursor of coronary artery embolization and MIs that these patients have. You know, in doing these CTs, there seems to be something unique. When you start to do more of the coronary alignment, you isolate the nun, and the nun, there is no drainage. I think of the concept of coronary drainage, right? If you align the left and the right, there is somewhere to go. When you isolate the nun, now properly commissure aligned, it typically starts, and that's where you have the most HALT. It's typically not right, not right. And the nun, when you have proper commissure alignment, is the one that you typically see signs of Valsalva thrombus. Of course, they're not MIs, but the RCA, sometimes the thrombus is right, you know, just a little below. I mean, what can we do better? We need to understand this phenomenon better.
I've shown you the bench test of the washout of the sinuses. But actually, if you do an injection with a pigtail very deep at the nadir of the leaflets, when you don't have the orientation of the valve, or you have, a very narrow situation, you see that the contrast dye stay there for many bits, so you don't need to go for bench test to understand there is a kind of stasis there. What we can do, I don't know exactly, but the point, for sure, valve expansion, you demonstrate with the previous Brazilian valve, that the laminar flow is there when the valve is completely expanded. Otherwise, you have turbulences, and I don't know the reason why, but probably the right coronary artery is the one that is most difficult to cannulate. So this means that this might be the anatomical background to have something that is more challenging compared to the left side. I don't know why. Anyway, I have to say hello. Thank you very much for your friendship. Thank you.
Thank you very much, Giuseppe. I'd like to invite João. He's going to talk about the planning of the TAVR procedure using deep CT analysis.
Muito obrigado. Giuseppe, safe flights and return home. Great seeing you again, my friend. All right, so this talk here, I am covering for my two best friends, Miho Fukui and Vini Bapat from Minneapolis Heart Institute. I had asked her to provide me with some of the slides. And so the disclosures is that we are great friends and we learn with each other all the time, and really fortunate to work on in the same institution. The app is available and free. You have the QR code there if you don't have for either Google Play or App Store. I'm going to have this slide again, so you should get familiar. So the idea of this overview here is to highlight what are the app features that we have. This is a compendium. I understand is a bit overwhelming initially because there are so many options that you can do. But because this is a procedure that is not so common yet, but it will become more of a common ground, we need to get familiar. And the first thing that we start with is the terminology. You heard from Giuseppe that there is a new vocabulary, starting from what is the new skirt, what is the new skirt plane, the coronary risk plane, we'll call it coronary risk plane, and then several measurements of the distance from the frame to the aorta, the concept of leaflet overhang that you heard, commissure, coronary protection, alignment, and everything. So, and each one of those steps, as you click, it will show you and do a very didactic way. The next thing is that provides the details of each TAVR valve. So each, and this is what it makes redo TAV more complicated than aortic valve in valve. Aortic valve in valve, you have the prosthesis, you know where the surgical leaflets end, and you know where the coronaries are. But here, the design of each valve, it's completely different. And even within the evolute, there are differences of where the coronaries start and where they finish. For example, in a 23 valve, you can see that the landmarks are from node 0 to node 5, whereas 26, 29, 34, they goes all the way to node 6. That's where the leaflet ends. So node 6 is going to be your neo-skirt plane, where the leaflets, when pinned out, they're going to be covering. You have a covered stent from the bottom all the way up, and that's where you need to assess, and that's something that you can manipulate when you're going to place a sapien into an evolute, for example. So neo-skirt plane. So I'm going to show this with an example. And then it has also CT analysis examples. We have tutorials there. So the same app will have a tutorial. Oh, I don't know how to measure. And we don't need a specific software, although Trimensio is coming up with a very, very nice module coming up probably sometime in April, June, for Redo Tab that will simplify and make it very easy analysis. Now, let me show, for example, here, when we try to identify the index tab as a sapien 3, and you have here a native bicuspid with moderate calcification, it was a size 29. As you put a 29, it gives you all the height, how long does the skirt go through. You might already know that, but it's good to have as a resource, and obviously the commissure alignment. As you try to then plan for the Redo tab, there are several measurements that we need to make to decide which valve are we going to use. I think this is another importance that this app provides. You cannot take in vitro measurements and transpose and put it again. The valves are always under-expanded. And so if you take a 29, or let's just put another 29 inside, you're going to create the Russian doll problem. And that is what we were trying to avoid to begin with. So here, because of the boundary conditions, you're going to measure at 3 levels, at the top, at the middle, and at the bottom. And then with that, you get the areas. And then with that, you get the average that is going to be selecting which valve you're going to implant. The coronary wrist plane, as we talked about before, is going to be determined by the lowest coronary, which is typically the left main. And that's where you're going to dictate where's your coronary wrist plane, where is your new skirt plane. In case of a sapien, the new skirt plane goes all the way to the top of the commissural tab. And so in selecting the second device, how are we going to treat this failed sapien? I can treat with another sapien, or I can treat with a longer valve, such as an evolute or an accurate, etc. And then depending on where you place the second valve, there's going to be some issues, there's going to be some issues about coronary access and leaflet overhang. Let me just move into this. And then the second sizing, as we talked about, you do those measurements, and that is going to determine the proper sizing that you're going to use. Okay, in this case here, you're going to use a ultra, and the mean parameter derived here was a 29. So the index is 29, and when selecting that, which the average area here was 577, you're going to look into that, and it's going to be another 29. In this case here, they're going to match, but not all of the time they will do so. Now, coronary wrist plane, we talk about that. That's where the lowest coronary is. If the coronary wrist plane is above the new skirt plane, you can do whatever. That's the ideal scenario, that the coronaries are above and the valve is below that. And then you can create a summary report. Now, one thing that we know is that the analysis of the CT, yes, it could be done right before the procedure, but most of the time it's done in separate days, in separate individuals. Or you've done today that you're going to do the procedure tomorrow. So there is a way that you can do that analysis and save that, so that when you go to the cath lab, you can use that information, have it readily available. Now, in tall valves, when an evolute fails, that is a bit more complicated, obviously because of the whole stent frame design. So here's a 34 evolute that fail. We're going to count the nodes. So typically we start at 0, 0, 1, 2, 3, 4, 5, 6. The leaflets are going to finish at node 6. So you're going to have to measure these several areas to average that. And you're going to measure several areas because your new skirt plane can be as worse as 6, right? That's where the leaflets end. Or can be 5 if you implant the sapien a little bit below, or 4. Does that make sense? The lower you go, the better you're going to have coronary access potential, but you're going to have leaflet overhang. So that's the ability that you can do. In this case here, the coronary wrist plane for either the left main or the RCA is at node 4. So can I still go for coronary node 6? You could go, provided that the vicinity, the area above that, you can still get some blood flow. So now you have to look into this concept that we talked about. You can play with the sapien depending on which level you're going to do. So if the coronary wrist plane is below the new skirt plane, which is the case here, the wrist plane can be as low as 4, you have low risk. Typically in cases where the evolute is failing from aortic regurgitation, you have the luxury of implanting it low. But most of the time it does not fail by AR, but rather a mixture of AS-AR. So here we were talking about node 6, node 5, or node 4. Second, TAVR sizing. Once you do the measurements of each one of those nodes, you're going to derive the area, and ultimately you calculate the average area. So in this case, it was a failed 34 evolute, and you're getting an area, because of the boundary conditions, expanded to 437. 437 falls into a 26 sapien. So a 34 evolute is going to be treated with a 26 sapien. And that's what we were talking about here. Now that you're going to have the new skirt plane below the STJ, you need to measure the VTA, the VTC, and measure the distance with a virtual circle. Understanding that that sapien 3 that you're going to simulate as a 26 might not expand fully to a 26. So we're still being a bit conservative when we do these measurements here. What I mean by this is, this circle here is the 26 circle. Will the sapien expand this evolute frame to all the way to the end? We don't know the answer, do we, Sushil? right? So we are trying to be a bit conservative in this case here. Maybe after some data that is coming from revalve and restore, we're going to see whether we need to simulate the full 26 or we can underestimate a little bit more. So here we do the measurements of VTSTJ, VTAL, and the VTC. And then finally you make the measurements and you see at node 6, these measurements are way too small and there is anything below 2 millimeters, there is a risk of coronary access as well as risk of potential sinus sequestration. So then you go one node down and you do the same measurements, now node 5, you do the measurements and you repeat that process. Here it starts to get better, both for VTA and also for the VTC. And then ultimately you can implant lower with much more leaflet overhang at node 4. Okay, so ultimately the decision was to go for node 5. Other things that also you can do from the app are the CT planning charts. Okay, if I decide to go with the short, Sapien 3 and Sapien 3, there is a way that you can download this PDF and use that as a reference. Some places are using that in the cath lab. We use that as well in the app. And you have also coronary access after redo TAV, some special techniques of implant, and also how to do that with very didactic videos on YouTube as well. And then there are videos about TAV or explant, showing how the devices and special techniques for both Sapien and for Evolut as well. And that's all. That's all I have. Thank you.
Thank you, João. I think we should couple of questions and comments further to the end because of. Do you want to say something, Sushil? Yeah.
If there's
We're
time.
mentioned.
Yeah. No, there's. I mean, the problem here, not a problem. I'm saying every patient is unique. It's not like TAV and SAV, and I think that's the clear message, right? So if you have a 29 Evolut that's in big sinuses, you know, you have to optimize the next valve deployment. If the next valve is completely underdeployed, and if you're doing a Sapien in there, for example, and it's underdeployed pinwheeling, that valve's not going to last. And so there's scenarios where you might put the Sapien above the native annulus. Because in those scenarios, you have room in the sinus. If you put a 29 below, I mean, you have a 29 and you put a 26 in the annulus, you're never going to expand. But if you have opportunities because the sinuses are big and you have a coronary wrist plane's okay, procedurally you want to put that valve in above the annulus. And the other thing is that, you know, when we measure these things on CTs, we're used to these frames, and it's not like the surgical valves, and there are risks with that as well. So if you have a failed Sapien and you're going to put another balloon expandable, it's not Ultra has a different attachment points, but the Sapien 3, the true dimension inside is a lot less because you cannot expand because the way the commissure attachments are, the calcium, and that calcium in that frame is a rigid structure, whereas a SAVR, there's nothing at the top. Those leaflets will go out, and you might get some room. With Sapiens, inside of a Sapien, you have a rigid frame that you cannot expand out. And so, you know, you have a 26 Sapien that's, you know, with an original annulus area of 530, 540, it becomes a little challenging. Sometimes that may be a 23 that you're going to get the best result with. And so these are the things that there are just so many permutations, and the app is great for you to think about things, but you have to sort of virtually, and maybe things like DASI and FIOPS and simulation will help bring some of this forward and sort of experience with these registries as well.
Yeah, and something very practical is that sometimes it's not very easy to have this. Sometimes you cannot do the final adjustments. During the procedure, sometimes it's not very easy, especially for tall frames. And sometimes you get stuck in some place. You have to just deploy where you are.
Yeah. Fabio, you have a comment?
Yes, a question for you guys. This app is incredible. It takes a little bit of time because it's many factors to consider. But, you know, the success of this kind of procedures is all about planning. But happened to me a few times that you plan, for example, for node 4. And when you put a Sapien inside it, when metal touches metal, it kind of moves up or down, and all your planning, half an hour, 1 hour that you spend there, node 4, you go node 3, node 5, and so how how can we avoid this and be more, have more predictability doing these TAV and TAV procedures?
I mean, that's a great question, and that's why we always need to analyze more than one possible node that gives you a range. And, you know, if a patient has only one possibility, I would be very careful. We are not that precise. I mean, I don't do these procedures, but Adam, I mean, is there a way that we could be a bit more controlled to...
Fabio, you know the answer to that question. Cut the leaflets.
No, I mean, I think leaflet modification in TAV and TAV is an important component, not only for coronary access, gives you wiggle room, but for flows later, other things, other options in the future. But I think your point is important with the tall frame. If you're doing a sapien in a core valve, it's the angle of the aorta. So I try to keep the sapien, I pull the flex cath way back and try to give it flexibility to move. And I try to keep it as central as I can in that core valve before I start going up. But if you have a horizontal aorta, all those things go out the window. You're absolutely right. As slow as you can do it, it becomes very challenging. And so you try to give yourself some wiggle room. In general, in my experience, I don't know what others think, it tends to move up, if anything, right? So, you know, I'd err on the side of being, you know, 0.5 millimeter lower than you think you want to be, because it's always going to seem to move up, so.
Jorge, you have a comment?
Yeah, no, thank you for the invitation. I just would like to reinforce that about this Professor Tarantino slide, that he talks about 95% of preprocedural planning on the CT. Now we know that we have a lot of data about the predictors of repairability that we can include, or we have to include now in our first CT analysis. For example, the sinotubular junction, the sinus of Valsalva diameter, and this needs to be also taken into account. But also, I just submit a paper with my professors in Canada. We just did the analysis of 200 CTs after TAVR in bicuspid and tricuspids, and was relevant for us that one of the main predictors for repairability was also the depth of the implant in short valves. So for example, if the depth of implantation was more than 90 to 10 versus shallow implants, this is another predictor for repairability.
Which one is worse?
So no, it's much better if you implant a little deeper than shallow, for sure. So this is something that we can take into account in our first CT analysis for the first valve, also based on the height of the coronary arteries, and which is going to be our target of the depth of implant, thinking in the second valve. And I did start with this question because in LATAM, we have like many countries that patients that are undergoing TAVR, at least 30 or 40% of the patients are bicuspid, and I was trying to detect if the anatomy of bicuspid or tricuspid could be different in terms of repairability, because we used to have like larger anatomies in bicuspids and larger ascending aortas, and we did find that the anatomy was not something significant in terms of repairability. But I don't know if you have like any any comment about the anatomy in terms of this planning.
I mean, the sinuses are usually bigger. So did you find that more often you could repeat TAV and TAV in a bicuspid?
No. Was the similar between tricuspid and bicuspid? Maybe also we can be biased because he's a highly selective patient, right? Probably we need to exclude like bulky calcium and asymmetrical calcium, and these patients were to surgery. But yeah, at least if the patient has the criteria for TAVR, we didn't find that.
Breno, I have a question for you here. So there was this almost a competition of let's split high. I want to avoid pacemakers, self-expanding valves, huh? 0 is pristine. I wanted to, go -1. Has that changed here? Are we still implanting high, obviously?
I think that we have to balance between the risk of pacemaker and the risk of or compromise a future redo TAVR. When you balance this, certainly we're going to move to the possibility of reduced TAVR if you're dealing with younger patients and low risk. If you're dealing with high-risk patients or older ones that will probably have only one device, maybe a shallow strategy would be still preferred. But for younger and low risk, certainly we have to consider these factors when we're deciding the position.
Yeah, we have to move on. Adam, you're the next, because we have a live case just after this session, so please stay here. It's going to be wonderful. Adam Greenbow, one case, please.
Okay, I was asked to present a case of TAV and TAV. So, 71 has a 29 evolute in place, getting more short of breath, and has aortic regurgitation. High risk for explant. Here is the CT. Draw. You just showed us how to use that complicated app. Is this patient at risk for coronary obstruction or not? I know I don't have a whole CT. But.
Oh, yes.
I mean, you can clearly see I've demarcated the ostium of the left and the right. From a VTC perspective on the left, it's not so bad. The right's got both. But node 5, node 6, it always seems to be that the coronaries are right on the edge. Do I need to do it? Do I not need to do it? Are they at risk? It becomes difficult, but the fact of the matter is, I think when you open up those leaflets, we can say that this patient is probably at risk. We know a lot about coronary obstruction now. I just want you to concentrate on A and B, because for TAV and TAV, it's essentially these situations. Because remember, the leaflets are on the inside of the cage. So it's, are you going to directly obstruct the coronary, or are you going to sequester the coronary, right? And then, so I think we just need to concentrate on those two concepts for a minute here. And like you've seen, when you stand up, what Giuseppe showed you, when you stand up the leaflets on the core valve, the evolute, that's what it's going to look like. It always seems to come just to the bottom of the outflow cage, around node 6. Okay, so what can you do about this? I don't see how we can get away without leaflet modification. And you can delay it. And you can delay thinking you need to do it, but I'm just not sure in the future. Because you either don't do the procedure, you can snorkel the stent, but you're going to put two pieces of metal right next to each other, so I don't understand what's going to happen to the stent. And if you could get the stent outside the cage to begin with, there's probably not a risk of obstruction, right? So I don't see snorkel stent working in this situation. You can modify the leaflet with basilica. Maybe it will splay it enough. Maybe it won't. There's a little controversy about that. There are some dedicated devices to help you do it, but just remember those dedicated devices are still performing basilica, right? Shortcut is basilica. It's just mechanical. Telltale is basilica. I just want to dispel some myths, right? There's nothing different about them. There is the new kid on the block, intraleaflet deployment called Unicorn, which we'll get into. And of course, dedicated valves, you know, Genivalve, J-valve are saying they grab the leaflets and they're going to prevent coronary obstruction. Well, that's not really germane to TAV and TAV, right? But also, even if the first valve is a Genivalve, if those leaflets happen to be up at the SDJ, you still have risk of sinus sequestration when those leaflets get open. Okay, so why do I think basilica is probably your best first line of defense? Because it's actually the most tested, right? It was tested in many patients in a prospective trial with very good results. There were worldwide registries after, more than 1,000 patients. The shortcut study was a prospective study of basilica. The Telltale study was a prospective study of basilica. So it's actually the most tested method prospectively. A little word about balloon assisting. If you are worried about the amount of splay that you're going to get inside a transcatheter valve, you can always take a small balloon after you cross, after you traverse, just open it up a little, 4 or 5 millimeter coronary balloon to widen the base so that it splays more. And this is virtually at no cost to you or the patient because it's inside the cage, right? So you're not going to flop anything into you're not going to make the leaflet break and flop into the coronaries because you have a backstop, right? You have a cage. So you could argue maybe balloon it, if you're going to do basilica, at least electrosurgical version, why not balloon assist it a little bit? Okay, so in this patient, we thought they were at risk of both. The right seemed to be worse than the left because the right had a risk at the VTC and based on VTSTJ. The left looked like there was a risk of obstruction at the sinotubular junction. Risk of sequestration is actually the best for basilica because any splay will allow blood to get into the sinus to fill the coronaries. So our choice for this patient was to basilica the left and unicorn the right. Remember, unicorn intraleaflet deployment, you really only can do for one. You got to choose. So we said, okay, we'll unicorn the right and let's just cut the left. So what did we do? Here is a catheter. So the first thing we want to do is just cross. The first part of unicorn is to just get across. So we are taking an injection here in the front and the side view to say we are at the bottom of that TAVR leaflet. In standard basilica fashion, leaflet traversal is done with a stato wire inside a microcatheter. You set your bovie at 50 watts and very short, 1 to 2 millimeters. You know, you put the bovie on and just burn through. You don't need to go any farther than the leaflet, so it's a very short burn. Then without energy, you now can push the wire down farther. And by the way, the skirt of the valve keeps it inside, so you don't have to worry. It's actually an easy push of the wire down further. And all you do in this case, so here's a picture to confirm indeed we are through the leaflet. And then, if you need to take a small coronary balloon to make a little room, go ahead. If you can get your microcatheter across, you can get to an 035 microcatheter and put a soft J wire in it and just stop there and leave it at that point in time. Right? So you now have access to an 035 wire through the leaflet. So now you take and turn your attention to the basilica part. So now we take a picture of the left leaflet. We do the same thing, traverse the left leaflet at its base with the same system. These are just AL guides. But now we're going to perform basilica, so there's a snare to capture the wire inside the ventricle in the LVOT. You grab that wire, you create the flying V surface, and you make your basilica cut. So now the risk of left sinus sequestration has been averted. My thoughts, the world according to me, in the world of leaflet modification, is that I think electrosurgery is the way to go. Because, first of all, it's safe. You do everything you want and nothing's exposed, and then when you're ready to cut, you cut. And because you're using electrosurgery, you're using the cut mode on the bovie, that is vaporizing tissue. You're not tearing tissue with a mechanical cut. So there should be less embolization. In fact, on some bench testing, when you look at a mechanical cut versus an electrical cut, you could see less distal embolization of debris, at least in bench testing. So to me, I find it easier to go with electricity. And this is not what I refer to, I mean, we still are using products off-label, but there is science behind this. You know, what does it take to effectively cut with electricity? You insulate the catheters, you focally denude the inside, you bend the wire so that you can concentrate your energy, and each one of these steps that you take increases your efficiency of cut with constant duty cycle, again, the yellow button. Now, there has been a dedicated wire that has been made to do exactly this, but to make it simpler. The curves are better, the wire is better insulated, so you only have to cut it, you only have to burn it 15 watts instead of 50 watts because they're insulated better. They have locks that are designed that just lock so you don't have to add on all the extra torquers. This wire was tested for Basilica, recently completed enrollment of 90 patients, 60 bioprosthetic that included TAV and TAV, 30 natives, 100% success. There was one coronary obstruction that actually happened because the Edwards valve was malaligned and the commissure and the pledget then obstructed the coronary, but actually the Basilica part was successful. And there were 3 strokes, one of which was disabling on day 1, the other with delayed strokes in patients with AFib, I'm not sure were even related. So once you've cut the left, by the way, the patients are stable, they're hemodynamically stable. Now it's time to do the unicorn on the right. So now you have your 035 J wire, right? You make a small, maybe a little bit bigger balloon inflation. You can then get a pigtail through the leaflet. You can get to your delivery wire. And now you take a 10 or 12 millimeter balloon and you just make a 10 to 12 millimeter hole in the leaflet. The goal here is not to tear to the free edge. The goal is really to make a hole, then deliver the valve into the hole and let the valve deployment tear the leaflet, because that will take the leaflet to the other side. If you take a huge balloon and tear with the balloon to the free end, maybe you get an eccentric cut, your wire goes around into the middle, now you deploy your valve in the middle and you trapdoor shut the coronary again. Does everyone understand that? So try not to bust all the way to the free end randomly, just get the valve in. And now you can deliver your valve. And now you have more freedom for this height issue, for the inability to place it exactly where you want, because you've taken the whole leaflet away to the other side. And here we are deploying one actually nice and high. We want this one up high because we want to get the best expansion we can get. We don't want to get caught in the annulus of the original, you know, that kind of stuff. And here's our final angiography, good flow into both coronary. So my take-home messages are, we're going to be doing this procedure. There's risk of coronary obstruction, and methods to mitigate this risk are already available. Now, dedicated devices may make it a little easier, but you already can do it. For me, Basilica is the one for most people. Again, whether you want to do that with a shortcut device, whether you want to do it with the telltale device, whether you want to do it off-label, you're doing the same thing. You can balloon assist it at virtually no cost. What do we do about unicorn? Should we go to unicorn for everybody? I'm not there yet because it's not as well tested. I just don't know about the safety of the mechanical tear of the whole leaflet. Maybe there's some increased risk. So right now, I've been reserving it for those at the highest risk, or a very calcified leaflet. I'm not sure it's going to splay. The VTC 0, the VT-SDJ 0, you know, maybe unicorn for those. Sure, there's the promise of leaflet excision, but we're not there yet. But for the time being, this is my algorithm. So thank you very much, and I'm happy to answer any questions.
Adam.
Thank you very much, Adam. It was really an outstanding review of techniques to modify the leaflets. That's one of the key points in TAV procedure. I think we just had a great session. We have to close this session because we have a live case in a couple of minutes. But our goals were definitely achieved. We discussed the selection, the planning of the TAV procedure, the role of CT, and in the final, Adam showed us how can we use techniques to modify the leaflets. Thank you very much for the presentation, for the presenters, the discussant, and the co-moderator, and I hope you can stay here to the next session. That will be a live case from Dante Pazanesi. Thank you very much.
I go down to the Probably not. But if you're talking about a real high risk of ADHD,
Ótimo. Assim. Eu vou abrir a sessão, chamar os debatedores e aí. Tá bom? Tudo bom? Tranquilo? Tudo bom? Vamos lá, mais uma? Está na hora, né? Good afternoon. Welcome everybody. Let's start this session. A very interesting session about stroke prevention in the atrial fibrillation setting. We have in this session one live case, one edited case, and one talk in the end of the session. So I'd like to invite all the panelists for this session. Dr. Aníbal Dalmonte is going to moderate this section. To me, it's a pleasure for me. The panelists of this session are going to be Dr. Enio Eduardo Gueiros, Dr. Francisco Chamier, Dr. Mard André Tebet, Dr. Salvador André Bavaresco Cristóvão, and Dr. Tana Jaten, who have a great experience in this setting of stroke prevention and atrial fibrillation. So I'm going to call Dr. Aníbal Dalmonte to invite. First, I'd like to invite our colleagues that are in the fair to go here to be present in this session, a very interesting session. So came to the main arena to participate, please. Let's do this a very interesting section together, okay?
Good afternoon, everyone. It's my privilege and pleasure to co-moderate the session with my friend, Dr. Jose Mangione. I had the privilege to be the vice president of SOLASI during his presidency, and I learned a lot from him. So I'm very happy to be co-moderating this session with him. So without further delay, all of these expert panelists have already been presented. So I think that if we have connection with Dante Passanese, we could move to the first, to the live case. Actually, Carlos, can you hear us from Dante? I think that Carlos Pedra and Marcelo Silva Ribeiro and Luis Nakayama will be the operator with Jose Ayrton Arruda as a guest operator. Can you hear us from Dante? We can see you very clearly.
Can you hear me, Aníbal, Mangione?
Yes, we can hear you.
Great. We were planning to have sort of a challenging case with appendage closure followed by ASD closure, but unfortunately, the patient had a huge ASD, and we had to send the patient to surgery, and another one with severe pulmonary hypertension. So this is a more straightforward case, and I hope you like. You know who is working with us as operators, and then we have a great team of echo people. We have Simone Pedra, Tito Palladino, and Andrea Vilela. And I would like to take this opportunity to thank the anesthesia team. They are doing a great job. All the nurses here and all the techs as well. And thanks for Boston for supporting not only the meeting, but this case. So let me start with some slides. So we're going to use the Watchman flex, and we're going to show the step-by-step technique. And I would like to start with thanking Aníbal Damonte. Aníbal, you started this kind of procedure with us 15 years ago, and you were instrumental for the development of this technique in Brazil. You did some cases with Fábio Sandri de Brito Jr. at Einstein, and then you came to Dante Pazanese, and I think we did 3 cases. So thank you so much, Aníbal. You are the man.
Thank you. You are so kind remembering, and we enjoyed very much working together. Thank you very much, Carlos.
Exactly. We've done live cases for PICS already. Anyway, so this is a 70-year-old male weighing 80 kilos, not 88. And the diagnosis was a recurrent paroxysmal atrial fib, which was documented on ER visits. As comorbidities, he has hypertension, dyslipidemia. He was a former smoker. He has a pre-diabetic condition, also sleeping apnea, a hypothyroidism, and also has some gastric problems, as you can see there, and diverticulum in the intestine. He was put on NOACs, but had recurrent GI bleeding, both on rivaroxaban and apixaban. And endoscopy showed some angioectasia of the duodenum. His CHA2DS score is 4, and his, of course, NOACs were discontinued, and his own amiodarone and allopril, atorvastatin, and thyroid hormone. So the next slide, we're going to show the ECG. He's on sinus rhythm right now. Myocardial ischemia was ruled out. He has no anemia. He's currently totally asymptomatic. He conducts a very active lifestyle. He's in very good physical shape. And yesterday we talked for about 45 minutes, and he's really convinced that this kind of procedure for him is better, suits him, his lifestyle. Next slide, you can see some echo pictures. I'm not going to dwell on them because we have much better pictures live, but there was LA and LV size that were normal, normal ejection fraction, some diastolic dysfunction, normal PA pressure, no thrombus in the left atrial appendage with normal velocities. And you can see some measurements there, but I won't mess your guys' mind because we achieved other measurements. But in summary, the derived diameter from the perimeter was 17 millimeters. As you can see, many pictures of the left atrial appendage, and it's kind of lipid, as you can see there. So there's a bigger measurement, another one, a smaller measurement. And this is the CT that was performed yesterday morning. You can see the shape of the appendage 3-dimensionally. Again, looking from the back, below, and cranial, you can appreciate the shape. It looks to me, it's not a chicken wing, probably cauliflower. It depends how much beer you drink. And another picture here. There two strategies to close this appendage. Take into account the landing zone, more proximal, more closer to the mouth, you can see there, and then we would have a landing zone of 19.7. This appendage is really superior, and it's not deep. In fact, it's a shallow appendage. And you can see here, there's another kind of strategy to put the device more into the appendage, more distal, but you run the risk of not covering one lobe, as you can see. And this, the landing zone more into the appendage would be about